I want to acknowledge that I'm speaking to you from the lands of the Wurundjeri people of the Kulin Nation and pay my respects to elders past, present and emerging. And a reminder that we're recording today's event, so you are welcome to turn your video off if you would prefer. Well, 6 weeks, 6 issues is our new weekly talk series in which we'll hear from some extraordinary Victorian leaders who are navigating the state's post-coronavirus future. They're the experts who for months on end have been working incredibly hard behind the scenes to shape policy and planning. And in this, our first talk, we'll be exploring the new normal, the path towards recovery with 2 of Victoria's leading health professionals. We'll start with a brief discussion and then we'll go to your questions along with questions from the public which have been sent in over the past few days. Now for our live audience, you can submit questions through Slido. You can also vote for the questions that you like. So we'll aim to get to as many of those as we possibly can. I'd like to introduce now our first 2 guests, Nicole Brady and Dr. Amanda Rojek. Nicole is a highly experienced health leader who was responsible for the establishment of Safer Care Victoria, a massive initiative to improve the quality and safety of healthcare across the state. And she's now Deputy Public Health Commander, working to respond to the COVID-19 pandemic within the Department of Health and Human Services. And Amanda Rojek has vast experience in emergency medicine with a focus on emerging infectious disease. She undertook her PhD with Epidemic Diseases Research Group at the University of Oxford and has frontline experience in the treatment of the Ebola virus. She's currently seconded to DHHS Incident Command Team. A warm welcome to both of you. Thank you so much for joining us. So Nicole, we'll start with you. The return to lockdown has been pretty sobering. On the modelling that I'm sure your team is doing, when do you think we're likely to see this strategy pay off with a consistent sort of decline in cases?
Okay, I needed to be unmuted. Thanks so much, Kate. Thanks for the welcome. And thanks also everybody for your interest and for joining us today, because it really is great to engage with as many people as we can so that we can get accurate information out. And we know how much people want to do the right thing. And so it's really great to be able to speak with people about how to do the right thing. As has been said quite publicly by the Premier and by the Chief Health Officer, Brett Sutton, we don't expect to turn the epidemiology, the data, the positive cases around overnight. We know that most people are watching the Department of Health and Human Services website on a daily basis and having a sharp intake of breath as they see that our figures are still much higher than we would like them to be in Victoria. But it takes about 10 to 14 days to have an impact of the sort of restrictions that we brought in last Wednesday. So we would be expecting later over the weekend or early into next week to be experiencing a change in terms of the epidemiology. So we want to see the figures start to plateau out, so level out, and then start to decline. We know that's going to take time, which is why that the shutdown for metropolitan Melbourne and the Mitchell area has been brought in for 6 weeks. You can't turn these sorts of things around overnight, but we're confident that we will be able to do so long as everybody does their piece and does exactly as we're asking them to do in regards to modifying their own behaviour and interactions.
So with that in mind, Nicole, do you think that we've seen the peak?
We can't be precise about that, but and Brett and again the Premier have been pretty clear about the fact that we are still experiencing and expecting some fairly challenging numbers to come through over the next few days. And then we would be anticipating, and the modelling would suggest that we will start to see it turn pretty quickly. So that's giving you not a precise answer because we're not working with precision so much as we can. We're working with human behaviour here. So it really is up to everyone to do their part to help us turn the figures around. So early next week is when we will be starting to we're paying close attention on a very daily basis to the figures, but that's when we would be expecting to see a better shift.
Amanda, there have been reports today that there are 150 healthcare workers in Victoria now infected. Does that signal a breakdown in systems and protocols to keep healthcare workers safe? And is that placing a strain on the system?
Yeah, it's a really good question. So what we know is during epidemics, we expect some healthcare workers to get infected. I think the first very important point is that healthcare workers are also members of the general population, and healthcare workers are still people that have families and friends at home and go out to dinner when they're not under restriction and things like that. What we have seen from the Victorian cases is what we would expect to see, which is that some of those cases are attributable to the kind of risk that we would have in the general population. And so that person's a healthcare worker, but it doesn't mean that their infection was gained in the workplace. It may have been gained through other activities that they undertake in their private life. We have very good confidence in the PPE that we have in this state, and also that we've got an ongoing supply of PPE, which has been one of the significant issues that we've seen associated with large numbers of healthcare worker infections internationally. So we're not expecting to see that. When we have seen healthcare worker infections, it's often been because of healthcare workers who have social interactions outside of the workplace. One of the benefits that we've had, that we've been given by the Victorian population by allowing us to invoke some of the restrictions that we did the first time around, is give our healthcare system some time to prepare for an increased number of cases. Always in that contingency planning, we plan for what would happen if some of our healthcare workers got sick. And so I don't think that we're in trouble at the moment. It's something that's been actively managed by the healthcare systems with the support of DHHS and the Chief Medical Officer. Kate, I think you're on mute. Sorry, I can't.
Okay. With that in mind, you've had vast experience in relation to the Ebola outbreak. Tell us what the lessons are and what you're applying in terms of that experience.
Oh, I mean, there's lots of difference and there's lots of similarities as well. I think the two things that strike me that are similar, one is how really difficult these viruses are. And I remember at various points in the Ebola outbreak, Mike Ryan from WHO will always say, the virus will always outsmart you. You know, we thought that we knew what we were doing and that we were starting to implement control measures that worked. And then it turned out that the virus lived in semen and it could cause secondary infections through sexual transmission long after the first cases. And we were seeing kind of outbreaks spotting and we didn't know why. And at various points just thinking, oh my God, the virus can do what? And, you know, that's very much the same here. This virus is a really difficult one to control because it has things like the fact that people can transmit virus before they have symptoms. And so people are often very good at doing the right thing when they know they need to be cautious. It's very difficult for someone to be cautious when they don't know that they have symptoms, which is why we have things like physical distancing and masks. And I think the second thing that's really important and stood out during Ebola is that we would have never been able to finish that epidemic had it not been for the strength and resilience and the leadership of the communities that we were working with. And really, it wasn't until we aligned with them and led with their knowledge of the communities that they worked in that we were able to really do anything meaningful. And I think it's the same here. And just because it's in our own backyard, I think we forget the importance of understanding the community that we're working with and all the different things that people are up to and what's important in their lives. And so we're really grateful that this in Victoria has very much felt like a shared endeavour. We're working with everybody to try and knock this thing on the head.
Actually, Nicole, that's a question that I wanted to pose to you because is it hard to maintain that community commitment and community leadership and that sense of self-accountability when we've got peaks and troughs?
That is one of the really big challenges that we're bearing in mind. And I think anecdotally, you get the sense that when we had the first announcement about a pandemic and we brought restrictions in that had a huge impact across the entire state, it felt like everybody really did the right thing. Now we've come into a second phase and we have this stage 3 level of restrictions across metropolitan Melbourne and the Mitchell Shire. Not everybody, but there is a sense that there is a part of the community that's thinking, how can I get around this? And the reality is that the danger for each individual in our community is much higher now than it was when we first went into the shutdown in March. We now have much higher rates of community transmission. So in which case we need everyone to do the right thing, to not have small parties of friends come around to your house or try and do some of those other things that people are doing because they think, oh, it doesn't really matter. as Mandy was just explaining, you might not know that you or your friend or the friend that your friend saw is symptomatic, and so therefore it's spreading that way. So we do have to try and make sure through forums like this that people understand the risk and what each of our individual responsibility is to do the right thing and to protect ourselves and those that we love. If you're younger and you're thinking, oh, I'm not going to get that sick, you might not get that sick, but your parent or your grandma or your friend who has got some other sort of chronic condition might get really, really sick as a consequence of catching corona, which is why we're all trying to do the right thing and spread that message.
And I think this second experience has, as I said, been sobering, but it's also sparked a conversation in relation to suppression and elimination. Can you talk a little bit about that and the thinking around that?
Well, so that people know just what the difference is, suppression means that we have we never wipe it out, but we have a tolerance for low levels of mushrooms of the disease, basically. So you get a small outbreak over here, and then we shut it down, we ring fence it, we do the contact tracing, and we're able to trace it down and stop that there. Elimination would mean that we have 0 cases of community transmission occurring within a population, so within Victoria, for example. So New Zealand has declared that it's reached elimination because they've had such a long stint of 0 community transmission, as has Taiwan, for example, as well. So there are other countries as well that have achieved that. As to whether or not we are going for elimination or suppression, that's a decision at a political level, really. It's a national cabinet and a state crisis cabinet council decision. But the truth is that no matter which we're going for, we would be doing exactly the same thing right now, whether or not we're chasing elimination or suppression. So it's where the long game is, and that's a decision that others will make, but we would still be making the same decisions and taking the same actions, no matter which it is.
And Amanda, understanding the source is clearly so critical in getting this under control. Most of the cases we're seeing now still traced to the hotel quarantine outbreak, and I know that there's an inquiry going underway, but what are some of the immediate sort of changes that have been implemented to improve the approach and to build confidence around hotel quarantine?
I'll let Nicole speak to the specific hotel quarantine question. I will say that I think what we do when we start to see outbreaks like the second wave that we have in Victoria is something called phylogenetic analysis. And so we kind of go back and we basically work backwards on a tree. So you could imagine we're in the leaves of the tree now, and then we walk backwards to the branches and then the trunk of the tree to look for the source. That work takes a reasonable amount of time, and there are some uncertainties still in that work. And so we know that hotel quarantine has been one contributor to this outbreak, and certainly a significant one to begin with. We know that it's not all that's going on at the moment. Our key issue really is around community transmission. And so the situation we're in at the moment, all of our focus as an operational organisation is on limiting community transmission, and then we'll allow the kind of the due diligence, very important work of working out what's happened in hotel quarantine be part of the judicial review. But I don't know if Nicole wants to talk more about that.
Thanks, Mandy. All I would add in is that the hotel quarantine program in Victoria is currently still under suspension. We don't have international flights arriving. There's been a national decision to limit the number of international returns back into Australia, and we're working through with colleagues in Corrections Victoria who are going to be manage the program going forward. But right now it's still suspended, I believe.
Right, thank you. And look, we're going to go to questions in a moment, but Nicole, I'll stay with you. Before we go to those questions, you are at the epicenter. Give us a sense. I can't even imagine the decisions that you're making every day and the volume of information that you're having to sift through. Give us a sense of how the incident command team sort of deals with that volume of information and the rapid changing sort of environment that you're in, and the decisions that you're required to make, every hour of every day. What's that like?
I think I would just pay such enormous respect to the colleagues that I work with. The leadership of Brett, of Annalise, and of the other people in the incident command team is extraordinary. The people who are running the enormous case contact and outbreak management team. I popped upstairs to have a quick chat with the leader of that team yesterday, and remaining calm, smiling, being collegiate, looking after each other is certainly something that makes this work, which is extremely challenging. It's an environment where people are looking out for each other and just checking in, you know, can I get you a chocolate bar? That kind of thing. So people are doing their best to make the right decisions, and there's a lot of leadership coming in from all different levels and looking out for decisions that are being made. But at its very core, it's a group of very committed people who are doing their absolute best to protect the health of Victorians. And I think it is a time to be proud of the public service that we have in Victoria. Across many agencies, there are many people working extraordinary hours with an absolute extraordinary commitment to doing the best to support the impact of the work. Because while we in public health make advice and support decisions in regard to how we can best protect the health, we're also extremely mindful about the impact that has on other aspects of health, mental health, other things that people aren't doing because they're afraid to go to the emergency department or the doctor, or they've got extraordinary pressure because of the impact on their business and their livelihood. So we're working with colleagues across government to try and make supports and to have those aspects of life feeding into the decisions that are ultimately made at the cabinet level.
Mm. A question from the audience. How do we convince people to look at what the science says instead of non-evidence-based social media discourse?
Oh boy, I mean, that's a tough question. There's no perfect answer to that question. And what I would say is I think that we have a responsibility as the people making the decisions and the people reading the science to be proactively engaged in public engagement. And activities like this, I think it's very easy when we're working really hard to kind of withdraw amongst ourselves. Again, I think one of the things that we're seeing in this epidemic, and is important in every epidemic, is community leadership. And so as a small group of people involved in the public health element of this, we won't be able to reach everybody. And what's been really nice is to see that there's community leaders who are taking on some of that information dissemination and engagement activity for us. But I mean, boy, if we knew the perfect answer to that, we would certainly be championing that. It's a really tricky thing, and there's lots of time and energy spent thinking about how we can reach portions of the population who may not otherwise be engaged in public health. And obviously, one of the things that we're working towards as an exit strategy from this pandemic will be vaccination. Vaccination is one of those areas where there's often a lot of controversy in some portions of the population around safety of vaccines and efficacy of vaccines. And so the department will start proactively looking at all of that work so that we can be clear and transparent about what we're doing and why we're doing it as much as we can.
Thank you. Another question, I think this one's for you, Nicole. How does the government choose which science model to follow? I've seen reputable scientists argue for masks and others argue against them. How are you sifting through that information to develop policy?
When you're working in using an evidence base to make decisions, you would go to the most trusted sources of evidence. So you would go to the most respected journals, and then you look at for those that have done the systematic reviews. So it's not based on one study in one place. You're accumulating and building the evidence together to come to an informed opinion. So we do that. We have a team that are doing those literature reviews and coming to us with those stronger evidence bases. And then we also go to very trusted sources like the Centre for Disease Control in the US. We trust that as a source. We go to the World Health Organization, Johns Hopkins University. So they're those very trusted and established sources of information, as well as the journals, which is where we go to support the advice that we would put up to then apply into the local context.
Thank you. Amanda, I think this one is from you. Some great questions coming through, and for our audience, keep those questions coming. Do we know how long the incubation period is? This week we've seen some cases with much shorter incubation periods than anticipated, and what does that mean?
Yeah, so the incubation period is basically the time between being infected and the point at which you start to develop symptoms. What we know is that can be anywhere between 1 and 14 days. And the way that incubation periods work are kind of a normal curve. And so you've got kind of an average where most people sit. For this virus, that's somewhere between 5 to 7 days. And so you would start to expect to get symptoms during that period of time. about 98% of people will be by 11 days, and then there's a small proportion of people that will be a little bit longer than that, so that's quite rare. The same thing happens on the other end of the curve. So there are some people that have a very short amount of time between being infected and then developing symptoms. Those are really, we expect those to happen, but we do expect them to happen rarely. And so when we see occasional cases, I think there was one reported in the media from New South Wales yesterday. I'm not familiar with the specific circumstances of that case, but I'm not surprised to occasionally see an example of that. That's certainly not what we would expect at a population level, though. Most people 5 to 7 days.
Great, thank you. Another question. We keep hearing about the possibility of super spreaders. Have we seen evidence of that in Victoria?
So what a super spreader refers to is one of the things that we use for epidemic modelling is a measure of spread, basically, and it's called the R0, and the measure is in a population that's completely susceptible. So there's no one who's immune either because they've had the disease before or they've been vaccinated. What's the average number of people that they would infect? For this virus, we think it's kind of 2.6, 2.7, which means if I was to get the virus and people around me weren't physically distancing, if they weren't wearing masks, then I would expect on average to infect another 2.6 people. And that's how we end up with these kind of epidemic curves that shoot up into the sky. Super spreading events is when we see a single person or a single transmission event which causes a much larger number of cases from that single event. We don't understand those very well, and we don't often understand why they happen. Particularly for this virus, we're not sure whether it has to do with the viral loads, the amount of virus that the person has, or whether it has to do with the type of environment that they're in. What we do know on average is the kind of environments that we think are more risky for transmission are places where people are close together, where people are indoors for long periods of time. So they're certainly when we try and look at risk, close proximity indoor areas are where we worry about kind of events where lots of people will be infected.
Thank you. Nicole, this is one for you, particularly with your experience with Safer Care Victoria. Given this pandemic is going to make a return, or possibly going to make a return, how will the health system learn as it goes, given there seems to be no let-up and there's so much pressure? Is there time to pause and reflect and to learn and to implement change?
We were actually having that very conversation yesterday with colleagues from Safer Care Victoria. So one thing that they do is they review negative and preventable negative harm that might occur in the health system. And they do so with depth and thought, and they gather all the evidence and they look at the human factors that were involved so they can make recommendations about how we could prevent similar things occurring again. And so they are starting to review where we've had healthcare worker infections, for example, to do those deep dives into what really happened, what can we do to prevent this going forward. And so that then I was a bit like, oh, we need to be rapid. The virus is spreading rapidly. So we're doing both. We're doing rapid reviews and rapid sharing of, we know that this happened and that happened, and let's work to stop that occurring again. And then also those deeper dives so we can get that more sophisticated understanding of what may have been preventable so that we can set up systems and processes and help protect the health system so much as we can.
Thank you. Another question from a member of the audience. If we try for suppression instead of elimination, is there a danger of ending up with a stronger strain of the virus?
Mandy?
Yeah, I mean, we don't know is the answer. So predicting what viruses will do going forward is imperfect, and always it's a danger. The worst thing you can do in pandemic science is try and predict what's about to happen next, because it's an easy way to be proved wrong. I think my gut feel is we wouldn't expect that. What we've seen from this virus so far is it's not mutating. So we've not seen a second wave where the virus is mutated and we're seeing a different, more severe illness causing or more easily spreadable virus than we did in the first. And so I would have no reason to expect that that's the case. We do know that viruses change over time, and it's the same as viruses have new generations. That generation of the virus is always slightly different from the one before. But, we can't predict that kind of moving forward. What we haven't seen in the 6 months to date is a really significant change in the virus for it to mutate and become kind of a more scary virus. And so my gut feel is we wouldn't expect that to come moving forward.
Thank you. Another question from a member of the audience. Are we in shortage of PPE, and is this the reason why DHHS is not necessarily telling everyone to wear masks where social distancing would not be practical?
No, we're not in shortage of PPE. The fact that we've had that longer run up in terms of the first beginning of the pandemic in Australia, and then we did have that lull as our numbers went down low, has given an opportunity for the health system, but also for the supply and manufacture of PPE just to spike rapidly. So just like I think you'll remember at the beginning, you couldn't buy toilet paper or hand sanitizer or soap in the supermarkets. And I was out and about the other day and just noticed you can now buy like AFL branded hand sanitizer. Who would have ever thought that a football club would be sticking their brand on a little tube of hand sanitizer? The same thing is about to happen with masks. We now have a very ready supply of masks already. I was up at one of the chemists the other day, and you can buy surgical masks for single-use purposes quite readily, and there is already a massive spike in circulation of those. But there is, as of last week, now a recommendation that if you're out in public and you can't be certain that you can maintain 1.5 metres of physical distance at all times, there is a recommendation to wear a mask. And we're able to make that recommendation with confidence because we know there is plenty of supply to support the first responders in the workforce, plus also other people who are working with vulnerable members of the community that must continue to work and to sometimes have to breach physical distancing. So there's enormous confidence about supply, and also about the fact that if we all wear a mask, if we go up to the supermarket or the market or do something else where we're not sure we can maintain that 1.5 metres of physical distancing, that it will reduce community transmission.
Thank you. Another question from a member of the audience. How reliable are the swab tests, and how reliable are the self-administered tests?
So they're pretty good. And they're good enough for what we need at a population level. No test is perfect. And so there's always a risk with a test of either a false positive, which is where the person doesn't have the virus and we see a positive result, or a false negative, which is where the person has the virus, but we see a negative result. I don't have to the top of my head the kind of sensitivity and specificity, which are the two markers of those, but certainly we've got a huge amount of confidence in the test, which is being done in our screening clinics. We're also undertaking work with institutions like the Doherty to keep doing research to think about tests that we can do that are potentially less invasive or require less protective equipment for healthcare workers. And so, for example, the Doherty Institute has led research on using saliva testing. And again, we see that test performs very well. And so we're continuing to roll that out and determine whether we can use that in the general population as a way of supporting people doing testing, which is a little bit less invasive and a little bit easier to do yourself.
Thank you. The next question is, there's been news this week of Australia's first approved coronavirus treatment option. Is it the silver bullet that it's being painted as?
Yeah, so there's lots of work going on looking at potential treatments. The big advance that we've seen in the last few weeks is the recovery trial, which is a trial of many thousands of patients in the UK. That has been quite a remarkable study, and Peter's a very good colleague of mine, so I'm quite biased, but I would say it's just extraordinary. When we look back at pandemics over history, if we were to normally do a clinical trial where we would enroll patients and try and work out whether a patient benefits from a treatment, from the day that you write your protocol to the day that you would enroll your first patient is normally about a year and a half. And so there's been really significant work done since the Ebola epidemic to try and contract those timelines, to try and cut through the red tape, but maintain our scientific validity and also our ethical conduct so that we can try and launch trials during the epidemic. We did some work looking back at pandemic influenza, and what was extraordinary about that in 1999 is that despite a pandemic, and it was a very mild disease, but it was still a worldwide epidemic that affected almost 15% of the world's population, there was no patient enrolled in a clinical trial that had the trial results published during the timeframe of the epidemic. So recovery has been a really remarkable achievement. What that study found was that for patients who have severe illness, who require oxygen therapy, that corticosteroids produce a benefit for that group of people. So it's not a drug that we would use for people that are mildly unwell or at home, but just in the kind of 15% of the population who we know may get severe illness. That's certainly not what we expected to find, and Peter, who led that study, has said that he's the most surprised of anyone. But one of the great reasons that's such a big breakthrough is that is a widely available drug. It's a very cheap drug, and it's a drug we know well. So it's a drug that's used in hospitals all around the world and has been for a long time. And that means that it's a drug that not only we can use in our high income settings, but we'll also be able to use in places around the world in low and middle income countries as something that's readily accessible and likely to provide a survival benefit there. So that's kind of been the big promise so far. There's still lots of clinical trial work going on to look at other therapies. Remdesivir is the other one that people may have heard of. The US have started using that drug on the back of some clinical trial evidence that it shortens the amount of time that people are in hospital for. And then we've seen some other drugs like hydroxychloroquine that we thought were promising to begin with that haven't demonstrated that benefit. I would say I don't think anything's been the silver bullet so far, and we probably don't expect to see a silver bullet. To begin with, the drugs that we have available to do clinical trials are normally repurposed drugs that are available for other indications. So, for example, we look at the drugs that we use for HIV and think, is it plausible that those drugs might fit? Or steroids, which is something we use for a whole bunch of different indications. Is it plausible that it would work for this virus? The next tranche of drugs that will start to be used in clinical trials are drugs where we have developed drugs specifically for this virus. Or we start to use things like convalescent plasma, where we take blood from people who have had the virus and we take the immune generating properties of that and then give it to other patients. And they're slightly more tailored. And I think where we do see a big benefit in treatment will be kind of in this next work over the next 6 to 12 months, where we have these slightly more finesse drugs.
So just a related question, it might be one for you, Nicole. Is it wise, an audience member is asking, to wait for a vaccine as a strategy when there's no guarantee of the timeline around when that might be developed?
We're not waiting for a vaccine as a strategy. We're trying to minimise the spread so that we can do everything we can to reduce the likelihood of someone catching and spreading coronavirus. We know that there is quite a likely potential, we can't be certain, but there is a risk, if you have it, that it is going to have long-term consequences to your health. So a vaccine wouldn't be helping that for anybody who's been unfortunate enough to have it. So that's why we all need to do our best individually, maintain our 1.5 metres of distance when we're out, only mix with people in your household, wash your hands, cough and sneeze into your elbow, and wear a mask, as we're now saying as well. So they're the main things we need to do, and that's why.
Thank you. The next question, is there any evidence of reinfection, and what does this mean to the current response and strategies?
Yeah, so it's kind of one of those areas where there's still lots of ongoing research. So what we know is when someone has been infected, certainly there's evidence to begin with that they have some residual immune function. That is going to wane over time. Because this virus is only really 6 months old, we're still looking at, and there are very big international studies where we closely follow up patients who have had the virus and continue to take blood from them over time to work out to what extent their immune function wanes and to what extent they're susceptible to reinfection. There's lots of emerging research. So there's both incidences where there have been case reports of reinfection. Sometimes we don't necessarily believe them. We think that the person has residual evidence of their initial infection, but they've potentially not been reinfected. They don't have a new infection. And so we're really reliant on waiting for these big international cohort studies where the work is done very diligently on a large number of people, rather than relying on these small case reports, because we may be jumping at shadows to do that. There's also at the same time non-human primate studies that are looking at this exact same thing, because it also has implications for a vaccine. So when we produce a vaccine, we'd like to know how long does the immune response last after we provide a vaccine.
Are there any statistics to indicate what percentage of the population may be immune?
Yes.
I think you're on mute.
The way that we do that is called a seroprevalence study. And so we will take blood from a population as a whole and work out what proportion of those have evidence that they've been infected by the virus. Again, there's quite wide variation in these. So there's some reporting of large countries that have had significant epidemics who only have a seroprevalence of between 1 and 2%. There are other places like Lombardy in Italy that has a much higher seroprevalence. And so that tells us that a large proportion of their population has been infected. The reason that people are so interested in seroprevalence studies is it gives us an indication of immunity, which is an exit strategy. And so the two exit strategies really are to have a vaccine, which provides immunity through the vaccine, or to have natural immunity, or to eliminate. And so what the low seroprevalence has been telling us is that waiting for everybody to get infected is just not a viable exit strategy. And that's why we're working so hard on continued suppression and on the vaccine.
Thanks, Amanda. And Nicole, this one's for you. What early lessons do you think Australia has learnt in building future resilience to another global pandemic?
It's a really good question. It's the being prepared part, the engagement in as broadly and widely as we possibly can to make sure that messages and evidence and science is being communicated to the public in a manner that everybody receives and understands and is motivated to act, and then having strong testing and that capacity within, as broadly and widely as you possibly could, is something that's just extraordinarily important. And to people to understand, again, it comes back to the communications part, but to understand the need for that. So very broad testing and very broad engagement would be really key lessons that we have.
Thank you. And maybe this one is for you as well. There are signs of community frustration, and yet we know this is a long road. How do we keep people's motivation up? Great question.
It is a really fantastic question. And that's not something that we can do alone or have the answers alone. It's something that we all, as individual members of our community, need to reach into and then our communities, our friends, our families, and think, how do we best get these? How do we all work to modify our own behaviour, those that we interact with? And that's something that we all need to do together.
A question from me. It's been interesting this week, and probably inevitable, to see the sort of petty interstate politics and barbs, etc. In terms of your health networks, is there close collaboration with your counterparts in other states?
Enormous. There could not be more support, more generosity, more goodwill than we have had from across Australia. It's so heartening in this aspect. In working in government, I've found that all the way as well, that whenever you reach out to someone interstate, they could not be more helpful and generous in sharing their learning and knowledge. And we've actually now got people on the ground from other states, I think, as it's been shared very publicly. So it works at a different level. So it's a wonderful aspect of the national government that we have.
Fantastic. There's a quite specific one that I'll let you choose who answers. What's the current thinking, Ari, the transmission on surfaces? Do I need to disinfect my shopping when I come home from the supermarket?
Yeah, so what we know about transmission is that most transmission occurs from close contact, and most of that is droplet transmission. And so droplet transmission is when someone coughs or sneezes or laughs, and droplets move from their mouth and then they're inhaled by the other person. And that's why physical distancing is so very critical. It is possible, well, we know as well that there is transmission probably from touching a surface that's contaminated and then either touching your eyes or nose or mouth. We don't think that that's a really significant contributor, although it is possible. And so really it's the droplet transmission that we worry about. The other thing in terms of contamination of surfaces is that the virus won't live forever on surfaces, and there's a degradation of virus over time. That depends on lots of things like the type of surface it is and the temperature of the surface and things like that. So I would say the key things when going shopping is absolutely wear a mask if you live in the Melbourne area. Try and stay away 1.5 meters away from people. washing your hands as soon as you get home, and then obviously washing fruit and things that you consume. But they're really the key things, and that's going to be really where the bulk of risk is.
And Amanda, a follow-up question for you from an audience member. Protective measures are all externalised. Is there any evidence that boosting your own immune system plays a preventative role? You're mute.
No, there's not. So there are groups of people who have immune compromise, and those groups of people will know who they are, and they'll be closely in contact with their doctors, and we're managing their risk, and potentially, particularly their risk when they come into hospital environments. For the vast majority of the population who have functioning immune systems, there's no evidence that certain supplements or things like that will provide a benefit above and beyond functioning immune system. And again, really the key things are around prevention of transmission, and doing your absolute best to put yourself in a position where you don't get infected.
Great, thank you. Nicole, for you, a question. What opportunities does lockdown provide for a change in the provision and thinking around the provision of healthcare? Is Victoria taking advantage of a change for the greater good?
Huge advantage. It brings concern about people not, especially those with chronic conditions or people who have got a suspicion about having something sinister lurking within them, that they don't go and get the care that they need or get the diagnostic testing that they need. So if you're in one of those two areas, then please go and see a health professional and do what you would ordinarily do. But for more regular check-ins and checkups, telehealth, so using this sort of forum that we do, or telephones, is definitely something that has risen quite dramatically as a consequence of the pandemic and people working remotely. That brings many benefits. It's much easier for people to have regular check-ins with a health professional this way than having to make the schlep into the waiting room and sit around, risk being infected, etc., etc. So that's been a huge increase, and it is something that we are investigating as a system, as how we maintain that once we get through the pandemic.
Thank you. A question from an audience member. Some young people, is their observation, think that they don't need to worry about this. Should we be promoting more stories that show how ill young people can get and the long-term consequences? Do we have an issue, do you think, in terms of age groups? Is that what you're seeing?
Yes, there is the highest level of positive results in Victoria of people aged 20 to 29. We do need to think a lot about how we engage with them. We think that frightening them is probably not going to be the way forward, but getting the message out about this is about you and those you love. So while you personally may not suffer much in regards to being a positive case and catching coronavirus, you could transmit it to somebody that you do love who will have really potentially very serious consequences. So that's the messaging that we're looking at. And if everyone listening could share that with young people in their lives, that would be a fantastic thing to do.
So a follow-up question from a different member of the audience. So is there a need for targeted communications to a younger cohort?
There's lots of different communications going on across lots of different platforms, engaging and partnering with people who young people listen to. I don't think they are necessarily going to listen to government. They are more likely to listen to their own trusted sources of information. So we're engaging with them to get the messages through that way.
Thank you. And a lovely question perhaps to end with is, looking back, is there anything significant that you do differently?
There's always plenty. We learn every single day when you're working in this environment. So there are many things that we would do differently. So I feel like I can't even give that as a specific response, except to assure that there is no stone left unchecked in terms of picking it up, having a look, reflecting, what could we have done better? What should we do tomorrow that we didn't do today, or we didn't do as well as we possibly could have today? We learn every day in this environment and then put those learnings into rapid practice. Mandy, I'll throw to you for that as well.
No, I don't think I could add to that. I think it's absolutely true. We know so much more now about this than we did 6 months ago. And we're an organisation that is very rigorous internally around reflection of things that we've done and how we've done them well and better, and also respond very quickly to emerging evidence. And so we're far from perfect, but we try extremely hard to make sure that we're always kind of checking in and seeing what we can do to make things a little bit better.
Well, look, that's a lovely note to end on. Thank you so much, Nicole, Brady and Amanda Rojek, for making the time today. And thank you to you and your colleagues who are shouldering so much extraordinary responsibility on behalf of the Victorian community. Thank you for all of the incredible hours and the expertise that you're bringing to this. Thank you. And thank you to our audience for joining us and for your really thoughtful questions. And we've got 5 more talks in this series, and bookings are now open on the library's website. So I look forward to seeing you next Friday. Thank you.
Thank you.